Thank you so much for the privilege and the opportunity provided to me. Let's start this session. The session is planned, monitored, and possible, redefining long-term pregnancy outcomes in kidney transplant recipients. So let's start the session with a case scenario which we face on our daily basis. There is a 28-year-old woman who is CKD on maintenance hemodialysis for past 2 years, and she reports with the amenorrhea in last 1.5 years now expressed a strong desire to get pregnant. So what do you do? What should be the most appropriate next step in the management? Would you encourage a pregnancy and say, yes, conception is possible, or refer her for gynecology for fertility counsel, proceed for oocyte retrieval or IVF therapy, or do recommend kidney transplantation first and optimize graft function before you counsel for family planning and other things? So I would give her a brief data on risk factors and the fertility issues, what happens in kidney transplantation and what happens in CKD. Clearly, we all know that live birth rate is high in renal transplant recipients. The adverse maternal or fetal outcomes are pretty way much higher in CKD patients, like preterm deliveries, severe preeclampsia, cesarean deliveries, and IUGR. And in any way, the hormonal disruption in CKD causes irregular ovulation and reduced fertility. So even the chances of getting pregnant in CKD patient is very less when we compare this to transplant recipient. Actually, we do not have data on epidemiology of how much is the incidence rate of pregnancy in renal transplant recipient, and the conception rates in these patients are actually underestimated, as early miscarriages and voluntary pregnancy termination are seldom recorded in our epidemiological data. Another question is, now that you had advised transplantation, she has gone through the kidney transplant surgery, and now you have the patient who is being discharged on POD7 with creatinine of 0.7 on triple drug immunosuppression. Now again she asks you that when can she start planning her family? What would you advise? Would you advise her to wait for 3 months, say that pregnancy is safe for like after 6 months or 1 to 2 years, or at this time only you would advise a contraception therapy? We all know that after the resumption of normal renal function after a kidney transplant surgery, there is lot of changes in hormonal therapy happens. For example, the prolactin levels decrease rapidly. There is a temporary change to hypogonadotrophic hypogonadism that occurs in 2 to 3 weeks after kidney transplantation, and levels of circulating sex steroids were suppressed when the patient was discharged but returned to normal range within 6 months of transplantation. So we know that the reported interval for time between renal transplant surgery and restoration of menstrual function varies from like 1 month to 12 months. The shortest reported conception period is just 6 weeks. So I would discharge the patient advising her the contraceptive methods. The ideal contraceptive method we do not know yet, but CDC had advised to use either hormonal method or IUD in uncomplicated patients, or surgical contraception like tubal ligation in women who had completed their families. So as we were discussing, the shortest time period from transplant to pregnancy is just 6 weeks. I had actually searched the database and found that this was the first reported case of pregnancy that is published in Germany in 1971. So she was a 20-year-old female, became pregnant 6 weeks after a disease donation kidney program, and was discharged on azathioprine and prednisolone. The kidney functions were normal, but there were signs of placental insufficiency and fetal growth restriction. She delivered spontaneously at 35 weeks with a 2.1 kgs of baby. But what happens was, 2 months after postpartum, there happens a severe rejection as she stopped her immunosuppression, and patient eventually died by suicide at 10 months of post-delivery. So there could be some advantage and disadvantages after pregnancy. We have to look on all those factors. So clinical lessons from this case was, the risk of very early conception is there after transplantation. Immunosuppression management and patient education is at most important. Placental insufficiency and fetal growth restriction are common and can even happen at normal graft function. The adherence to immunosuppression is critical in postpartum period also. Coming on to her question, that what could be the ideal time for pregnancy in post-transplant recipient? So this is a very good study which was published about the timing of pregnancy. It stated that in the first post-transplant year, there was an increased risk of acute all-causes graft loss and dense-censored graft loss, while pregnancy in the second post-transplant year was associated with this increased risk of death-censored graft loss. So most of the guidelines recommend at pregnancy is safer after 1 to 2 years of transplant if there is no recent episode of rejection or ongoing infection. The blood pressure should be normal, there should be a stable graft function of around less than 1.5 of creatinine, and there should be absence of proteinuria. The teratogenesis should be stopped before 6 weeks of conception. So we fear, when we counsel for pregnancy, we fear for infection, the teratogenicity of drugs, adverse fetal outcomes, maternal outcomes, even spontaneous abortion, and IUDs. So the first question is, do we fear rejections? Pregnancy is a state of immunological tolerance associated with immunodepressant activity of lymphocyte that creates a tolerance to fetus, which might benefit the renal allograft also. As such, in the data, we do not find an increased risk of rejection in pregnant patients, and the rate actually lies from 1 to 14%, which is comparable to our non-pregnant kidney transplant recipients. So, but there is also a challenge when we diagnose rejection, because the preeclampsia also kind of have same kind of symptom. For example, sudden worsening of hypertension and marked increase in the proteinuria is also maybe noted in rejection. So it makes a diagnosis pretty challenging. So the outcome actually depends on episodes of rejections, poor graft function, proteinuria, obesity, the patient-related factors such as obesity, age, previous infections, or diabetes mellitus. This have been, which we already discussed. So again, coming to the next question, which we fear the most. Can infection complicate the case? Yes, very much. Two types of infections which we commonly see. One is CMV, which is kind of very deadly virus, and the transplacental transmission rate is around 32%. The first trimester infection is associated with up to 50% of neonatal sensory neurological morbidity. Serological testing before 14 weeks to identify primary infection is important, and within the 3 months of conception. Valcyclovir is now used in pregnancy to prevent and treat congenital CMV infections. The most common symptoms in the baby could be chorioretinitis, hepatosplenomegaly, microcephaly, basically the CNS symptoms. Again, the UTIs. UTIs can also complicate the cases in 40% of the cases. So screening of UTIs is important and should be performed with dipstick at every visit, with urine cultures at 4-week interval, and asymptomatic bacteria should also be treated. Coming on to the immunosuppressive agent, the 4 pillars of immunosuppressive agent which we commonly use is CNI, steroid, MMF, azathioprine. This is a list of drugs. I would say MMF, sirolimus, belatacept are not compatible and should be stopped before 12 weeks of conception. Cyclosporin, azathioprine, prednisolone can be used, and there is unclear evidence of ATG. A brief about these drugs. The placental metabolism of corticosteroid is efficient, with 90% of the maternal dose being metabolized in the placenta before it reaches fetus. And there is also a pharmacokinetic alteration in CNI levels. The dose adjustment might be required as the drug levels might increase to 20 to 25% to achieve the target concentration. But here also one important thing is there, that the free tacrolimus concentration might be higher in the pregnant patient rather than in non-pregnant women. Azathioprine is considered safe as it passes in the fetal circulation, and the fetal liver lacks the enzymes that is required for the conversion of active metabolites, and therefore the fetus is kind of protected from the adverse effect. Breastfeeding is not discouraged. When we talk about the drugs, the estimated absorption of tacrolimus from breast milk is around just 0.23% of weight-adjusted maternal dose. And cyclosporin, even the exposure to corticosteroid is very less, so we should never discourage a woman for breastfeeding. If we see the outcomes, there are some important studies which has been published. From these studies, we know that the live birth rate is more than 80%, but yes, there is risk of preterm deliveries and miscarriages and preeclampsia. Now, the important question is now because the patient has resumed her normal menstrual period and the hormonal levels are okay, and she has strong desire to get pregnant, would you advise assisted reproductive techniques to your KTR patients? There is not much published data on this, but I would say this: whatever the regimen for ovulation induction we have is for normal GFR patient. If even we have a reduced GFR, or we have to reduce the dose and use a mild kind of dose, as gonadotropins are cleared by urinary excretion, and the dosing guidelines are based on women with normal renal function. So in impaired kidney function, the clearance might be reduced and there could be accumulation of the drug. This could lead to ovarian hyperstimulation. So we should use a lower drug, and especially in the reduced GFR. And patient should be informed that the monochromic twin pregnancy risk could be there, and that can increase the risk of the twin deliveries, triplet deliveries can increase the risk of preterm and IUGRs. So coming on to our result, what is the outcome in our Indian patients? This was a study we published recently in 25. There were 182 KTRs. The median age was 30 years, and the median time to conception was 4 years. The important thing and the good news was the successful birth rates were more than 90%. And there was no risk of gestational diabetes, UTIs, and other congenital abnormalities, and rejection rates were also not that high. But what concerned was the rates of preterm deliveries that goes up to 60%. The rate of low birth weight was around 50%. Then the rate of abortion, new onset hypertension, preeclampsias, and cesarean deliveries were around 70%. So these were the bad news, but yes, we do have more than 90% live birth rates. So these were the short-term outcomes, and then what about the long-term allograft and patient outcomes? Does the pregnancy have any effect on the long-term allograft function? In our cohort, the eGFR was maintained at 1 year post-pregnancy. The mean serum creatinine was 1.2. The median follow-up period here was 6 months, ranging from 14 months to 21 years. The graft failure occurred in only one patient, and 4 patients died, resulting in a dense sensor graft failure for other causes. So in other studies also, we can see that the graft and the patient survival from transplantation to the follow-up of around 15 years in women who conceived after transplantation did not differ from rate observed in the matched cohort, and there was no difference in the group between the long-term graft outcomes. But here we can find some difference and discrepancies in the study. For example, this study found that pregnancy impacts the rate of eGFR decline in allograft, and the post-pregnancy biopsy showed that there is increase in the vascular injury, which could be a potential mechanism. However, there was no increased risk of graft failure or reduction by 50% due to pregnancy. In the meta-analysis also, when we think about the long-term analysis, the risk of allograft failure or graft loss was similar between the pregnant and non-pregnant females. The all-cause mortality rate was also comparable, and the creatinine levels were significantly lower in pregnancies compared to after deliveries. So what are the advantages here when the patient conceives after transplantation? Yes, there is a high risk of live birth. There is improved fertility compared to pre-transplant CKD patients. There is opportunity for motherhood and normal life, and there is a lower risk of fetal loss when we compare this cohort with the hemodialysis patient. Plus, we do have a risk for preeclampsia, hypertension, low birth weight, and graft dysfunction loss is very less. So why do a woman still choose pregnancy after kidney transplant? There's cultural expectations of motherhood. A womanhood is closely tied to motherhood. A woman may feel incomplete, stigmatized, or pressurized if she doesn't bear children even after chronic illness. Transplant gives her a second chance. If I am well enough to live, I should be able to be a mother. Visibility of illness matters. Society often underestimates the ongoing risk, encouraging a KTR to resume her traditional gender roles quickly. So the social realities behind the pregnancies is like the decision to pursue pregnancy is rarely just medical, it's deeply social, cultural, and personal. If we talk about the monitoring of this patient during pregnancy, we had discussed about the teratogenic drugs and blood sugars and blood pressure. The blood pressure and infection risk should be screened routinely. But there should be a bi-weekly monthly visit for nephrologists and gynecologists looking for the proteinuria, creatinine, and blood pressure. We should be doing more surveillance for our CNI levels and strict vigilance for BP, blood sugar, and infection. So the planned pregnancy with deliberate optimization made by multidisciplinary team approach ahead time leads to increased successful outcomes. Now, I would like to tell you about some real life scenarios here. So there was a 26-year-old female had got transplant 1.5 year back with a stable graft function presented with amenorrhea. On evaluations, she was found to have 6 weeks period of gestation, and she was on MMF and told about the profile, what are the risk factors the patient can have with MMF, but she decided to continue pregnancy. She delivered a healthy baby of 2.5 kg baby girl at 36 week of gestation. The problem was she has some kind of congenital problems, microtia was there also, but there was no sensory neural deafness, and she is now undergoing surgery at 6 years of age. So this was the problem she had. She was told about the risk factor, but it was her decision to continue pregnancy. So I also asked one of the patient to tell her about the journey, what she had after pregnancy, after her kidney transplantation. She had narrated the story for us that becoming a mother changed my life, but becoming a mother after receiving a kidney transplantation gave me a second chance to live and love more deeply than I ever imagined. There was a time when I wasn't sure if motherhood was in my future. The toll of kidney disease took on my body was overwhelming, physically, emotionally, and mentally. The dialysis were draining, and each day felt like survival rather than living. But through it all, I held on to hope that one day I would be strong enough to carry a child, to chase after a toddler, and simplify be there, present, and alive. Then came the call. A kidney became available, and the moment is forever etched in my memory. It wasn't just a chance for health, it was a chance of life, and that life came my greatest gift, my child, now 2.5 years into motherhood. Every day feels like a celebration of resilience. From the first kick in my belly to the first step, first word, and every giggle in between, I don't take a single moment for granted. So, this was a story from our side. We might have a difference in opinion should we allow pregnancy after transplant or not. But yes, as for her, it was a great moment. Thank you for being such a good audience, and thank you all.